welcome you to the first AccelaRATE forum from White Plume Technologies. We're very, very excited to have you, and we thank you for your time. We've got a room full of White Plumers here with us, but before we get into those introductions, I just want to give a brief discussion and framework of what we're trying to accomplish. The premise of this forum is that it's a user forum led by you. All right? It's important for us to make that clarification early on, because this really is a tool that you need to understand is yours. And we'll talk about opening our toolbox in a little bit. But this.
The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. This is Kenny Walls with White Plume Technologies. I wanted to welcome you to the first AccelaRATE forum, and we are very, very appreciative of your time and effort, and we will do our best to make sure that it's valuable for you this morning. I've got a room full of plumers with me, and we'll introduce those as we go along. But before we did, I really wanted to spend a little time talking about what this forum is and why we wanted to provide you the opportunity to participate. The what of the forum is pretty quite simple. This is a user forum that is led by you, and I want you to hear us on that this is your tool. You'll hear us talk about throughout this presentation kind of opening up our toolbox and meeting our rock stars and that type of terminology, but this is a tool within that toolbox that is specifically yours. It is led by you. We envision that you determine the topics, you determine the workflow, you determine the needs, and you allow us to serve you in that process. So we facilitate that, but it is simply led by you. It's designed to spawn discussion and really motivate positive change. And we'll get into this a little bit more as we go to the next slide, but really we do our jobs well when we give you that information to say, hey, I didn't realize that. I can do this a little bit differently. I can do this a little bit better. And that positive change is our reward for facilitating the process. And quite frankly, at the end of the day, it allows you the tools to develop a much greater return on your investment. We cherish the relationships and the investment that you have put in us, and we want this to be a vehicle to allow you to really expand those. And again, we're kind of service-oriented around here. People think of us as a software development company, and quite frankly, we're a service company that happens to develop pretty good software. So we want this to be your platform to help us determine the rock stars that are in this room, myself excluded, to determine how best to serve you. And it's a network of peers and friends. It's intended to be a very enjoyable experience. You will learn things about people on this call that I promise you've never known before. We all have jobs to provide for our families, but it is very important to do those well, but do them well in an enjoyable environment. And we want to make sure that any interaction that you have with us is excellent, and you look back on it as an enjoyable experience. And then the best compliment you could ever give us is those guys at White Plume have our backs. So we really want you to hear that as we go through. So the why of this is really kind of a historical perspective. I had the great pleasure of serving on the team when we first rolled out these products in 1999. And when we rolled it out at that time, we had a pretty quick start. We turned around within a short period of time, and there were 6,000 or 7,000 providers around the country that were utilizing our products. And when we were sitting in team meetings, we would evaluate where the customers are drawing the most value. And at that time, the customer perceived the biggest value in the efficiencies gained from collecting the charge data. At that point, we were scanning charge tickets, so collecting the data and the time efficiencies that were gained from that. That was the low-hanging fruit. But we knew that the nugget of gold that was there was housed in the rules engine behind that data collection. So what we saw, and we saw this pattern of clients that were really not fully leveraging SMART. And when we asked ourselves why, it was, well, quite frankly, they feel like they've driven enough value out of the application through the time efficiency saved, and that's just icing on the cake. So we spent a lot of time trying to understand that icing was really good for them. All right, and that's kind of the pattern that's repeating now. We've always been very driven, again, service-oriented to help you mine that gold. And even though this series of forums is designed by you, we had to pick this first topic just because it was getting off the ground. And the biggest nugget of gold that we could see was in the rules engine and creative use of the SMART engine. So that's why this topic was selected. You'll have an opportunity later on in the presentation to talk about other items as well. There's a great power in encouraging and actionable dialogue. There's a book that we read around here often, and it's a great book. It's called Back to Balance. It's written by Dr. Haley Fisher. She's a pediatrician, actually married to a pediatrician as well in Colorado. She's also the CEO of MGMA. And there's a part in this book that I'm going to read to you, and I apologize for reading, but it resonates with me. And the premise of the book is really restoring the balance and bringing back the art of medicine versus the science and business of medicine. But Dr. Fisher says this. She said, there will always be a gap between the illnesses medicine faces and science's limitations in treating them. And there will always be a need for people to bridge that gap. Well, that's from a doctor's perspective and the clinical perspective. From the people in this room, the people on this call, the perspective might be a little bit different. But there will always be a gap between the duties and needs of your jobs. And quite frankly, they're hard. Your jobs are hard. It's a lot of information. It's constantly changing information. And it's really a hard job. And there will always be a gap between the duties and needs of those jobs and the tools to support that. And we want to bridge that gap. So that is the why and the power in that conversation. The next topic about an inchworm is really the genesis and the evolution of this company. Can be really just kind of distilled into the image of an inchworm, because you guys early on, the early adopters of our product line, we have a participant here that's been with us for 17 years. They pushed us to do better, and then they came along, and they pushed us to do better, and we came along, and they pushed us to do better, and they came along. So that inchworm effect is a good thing. The flip side of that is that inchworm effect has given the product line an immeasurable depth of ways to use it, and it's almost impossible to grasp the power and depth and functionality of the system. So the more dialogue we have about it because of that inchworm effect, the better. I mentioned opening up our toolbox is not only healthy, but it's critical, and then relationships matter, okay? We're going to spawn dialogue and discussion, we're going to launch an inline poll question now, and you'll be able to actually select that as you move through. But the poll question from that standpoint is, how well do you think your practice leverages AccelaSmart? Okay, and we'll actually have one right past this, but how well today do you think your practice leverages AccelaSmart? You have options that said that we absolutely are excellent, we rock, and we should be a panelist for this forum. And everything from that down to, we only use White Plume delivered rules. We don't build custom rules. We don't really leverage that. And quite frankly, know that there's not a wrong answer in this. This is just a dialogue. You'll hear us say it time and time again, it all starts with the discussion. So you might think that you're slightly above average in your use, and then you may have a few custom edits that you've leveraged. Right. The next question with respect to relationships matter is this. We're going to turn it over from this perspective. Earlier this month, one of the participants on this call visited the Taj Mahal and other areas in Nepal. Who is this servant-hearted traveler? Choices are Sally Miller, one of our incredible CAEs, Angie Caper from OI, Stuart Wiggins, Carl Giles, or Diana Hoskins. I'll go ahead and give you the answer, and it's the next person that you'll hear in this dialogue after me. That would be one Stuart Wiggins, who just this week returned from a 10-day trip, and how many hours on a plane?
Oh, innumerable hours on the plane, probably at least 48 hours or more in planes and airports and such. So if I sound like I'm in another time zone, I might be. So in 2 days, I existed in 5 different time zones, and one of them was like 11 hours and 45 minutes away, because Nepal is on the quarter-hour time zone and India was on the half-hour time zone, and then we got back over to Amsterdam and Detroit and here. So I think I know what time it is. I think I know where I am, but I'm back home now.
And those of you who know and engaged with Stuart in the past, he has a great servant-based heart. He serves you well, tries very hard to serve you well. But he took that with him on the plane too. He was serving some of his friends that were missionaries in Nepal. So we're grateful to have him back. All right, so in terms of the agenda, well, before we get to that, I want to try to talk through some housekeeping issues. I would like to introduce Ms. Shelley Wiggins, and she'll talk to you a little bit about the housekeeping aspects of working through the balance of this show.
Hey guys, as you know, on most of our webinars, because of the number of attendees, we have to keep everybody on mute. So if you have a question during the webinar, feel free to send those to me in the question panel. If you have the question, chances are someone else does as well. And so after each of our presenters share their topic, there'll be an opportunity for them to answer questions. So just send those questions as you think of them, and we will then relay those to the presenter, and they can answer those based on their topic. If you want a copy of the slides or a recording when we're done, feel free to send that to me as well in that question panel. We'll follow up with you afterwards, and then as always, there will be a survey at the end, so please complete that when we're done.
All right, and thank you. And back to the agenda items, you know, when you really kind of peel back the layer of the onion, so to speak, on AccelaSmart, there's a tremendous amount there. Again, back to the inchworm effect. We wanted to kind of break that down into 3 themes. One was workflow adaptation and scripting. We have a fine user by the name of Katina Burton from Cardiovascular Institute of the South in Houma, Louisiana, that will be presenting that, and that will be first on the dock. Katina has a great opportunity to go to a elementary school pageant right after this, so I'm sure she's got a smile on her face. Next, we'll move to edit maximization. Kathy Dorby from Capital Care. We installed that account. We worked with Capital Care starting in 2000, and Kathy will explain a little bit about her use of AccelaSmart through that maximization theme. And then Connie Dodson in the Shannon Clinic out of San Angelo, Texas, will talk to us about a challenge that she saw and she overcame. And it really is a great testament to the interoperability and the integration and the teamwork that was applied through vendor relationships and just her leadership. So those are the 3 themes. We're going to start, like we mentioned, with Katina's theme from workflow adaptation and scripting. And with that, I will turn it over to Katina.
Good morning, everybody. As mentioned, my name's Katina, and I'm the Director of the Business Office at Cardiovascular Institute of the South. We've been on White Plume since about August of 2014, I believe, and love it. It was a great transition for us from electronic paper super bills to more of an electronic process. And as we moved to an electronic charge capture process, I'll kind of just give you a little bit of the background as to what I'm going to present on. For us, it was very difficult to let go of paper because we had a team of coders that would review every single super bill and every single charge that was on the super bill. And they would also review if there was an opportunity, or they would also review everything to make sure everything was appropriately marked. So the staff would sometimes forget to mark that they did a particular test, and so we may have missed that charge. And so for us, it was difficult to let go of having a coder review 100% of every fee ticket for fear that we might miss some charges moving to an electronic charge capture software. Who would be reviewing all of that, and how would we make sure everything got marked appropriately? So in brainstorming and coming up with a way to make that happen in a more automated fashion, White Plume helped us kind of come up with this idea that we would send an appointment type code as a message as a charge line item. So basically what happens is when we check in an appointment in our practice management system, which we use NextGen, when those appointments are checked in, DFT messages are sent to AccelaCapture. And if you can look in the screenshot that's on the screen right now, this is actually what it looks like. So for instance, we put all of the patients' same-day encounters on the same encounter. So if they have multiple appointments for the same day, we utilize one encounter. And so, for instance, this patient...
Hey, so Katina, can I clarify that? So in your scheduling system, it's one encounter number, but multiple appointment events. Is that, am I saying it the right way?
That's correct. So a patient could have an appointment for an office visit, an echo, cardiogram, and a nuclear perfusion. And so when we check in those appointments, we would check them in, and they all are linked to one encounter number, one encounter. And so we would need to put all of those charges on the same encounter. And that's how we figured there would be an opportunity to miss charges, because we didn't want to create an encounter for each appointment. So we wanted to lump all of those appointments together on one encounter. So what we do is whenever those appointments are checked in, NextGen sends the appointment code to White Plume, to AccelaCapture, in the form of a DFT message. So it looks like a dummy charge line item. So if you look on the screen, can we go back to the other screen? Thank you.
Yeah.
When you look on the screen, this patient was scheduled for an echo and an established patient visit. Well, we identified these sharp codes. For instance, echo is ECH, and established patient visit is EP. And so those event types come in to AccelaCapture when the appointment is checked in. So it's transmitted automatically. So the minute the patient's appointment is checked in, these appear in the fee ticket. Next slide, please. So what happens is whenever the coders are ready to batch the encounters, they'll batch the encounter. And I purposely did this example by not marking any charges in the fee ticket. So I was the technician that day, and I was the nurse that day, and I just didn't mark any of my charges because we were super busy. So we just went through and completed the encounter. Well,
Excuses.
I know. There's so much going on, and so so we just completed the encounter. We didn't mark anything. We just completed it. And once it's complete, it's ready for the coder, obviously, to batch and smart. So the coder doesn't know that there's no charges in there, or maybe half of the charges are marked. So she imports it, she creates her batch, and I pulled this encounter in, and at this point, you see there's nothing marked, but imagine there's a series of 25 encounters in here, and we don't want the coder to have to go through every single encounter to see who marked charges and who didn't. So we validate it at this point. So next slide. So once validated, we have these custom edits that will fire based on these appointment types. So the coder, it jumps to the encounters that have edits that fired. And so in this example, the coder would receive an edit that an ECH appointment is scheduled, is made, but there's no corresponding CPT code. And the same thing with the EP. So we've made the appointment, there's a charge line item, but there's no corresponding code. So next slide. So, and this is what an example of what the edit looks like. So for instance, on the EP, it needs to satisfy one of the particular CPT codes. And so, so we're looking for those, and once those codes are entered, then it would meet the edit. And the same thing on the ECH. I put the full range of possible codes for that appointment type in that rule wizard, and it's looking for any of those codes. So, so we have done this for all of our event types. So next slide. And so now I have added the appropriate codes, revalidated it, and the revalidation was successful. Next slide. And then this is kind of just a short screenshot of what the codes, all of the edits that we have. We have over 90 edits because we have several appointment types. We have a lot of appointment types. And then the other thing too is that if you'll notice, like the first probably 6 or so edits, you see they all kind of have that 1 day EX. Well, that's because some of our particular procedures that we do always are billed with maybe sometimes up to 6 codes. So we had to get really creative in building these rules to say we need all of these combinations to occur in order for the edit to appropriately fire, so we don't miss any of those codes. And so it took a series of edits, and it did take a lot of time to build, but I have to say that it was probably our surefire way to make sure that we did not have any missing charges.
And go ahead, Tina. One thing some people may be asking is about those dummy event codes. We're treating them as procedure codes, but we can assign an attribute to them so that they don't pass to NextGen, so that they're there for the purpose of your editing, so they serve that, but you don't have extraneous garbage going in that you have to purge or deal with once you get to NextGen.
That's correct. And so I actually do that, so I don't need any intervention from Plume. We build these edits all the time, go in and suppress them from going to the practice management system, so it doesn't go into the system and you don't have a matching code or junk in your practice management system. So it really just warns you in Accela Smart, and then it drops off before it even imports into the practice management system. And the things that we have noted from doing this is that the charge capture is much cleaner. We're able to capture everything, and for us, and I'm sure most practices, if you're billing things on same data service, you need to have, sometimes you have to append modifiers, and that was our reason for not having different encounters for every single appointment type. And then the other benefit is obviously it reduces the potential from lost revenue and from missing the charges in an automated fashion. And that was our goal, was that we were going to remove ourselves from paper, but we still didn't want to have a manual process, because even when we were doing the 100% review on paper, it's a human error that you could still miss those charges because they may not look in all of the charts to see everything that was done. This way it's automated, so they will immediately get the edit. The computer is doing the heavy lifting for them. In addition, it prevents overbilling. So sometimes they may mark it, but the patient may not have had that service. So they can see there's no corresponding appointment type for those codes, which can be beneficial. And then the other item is that it eliminates the need, again, like I said, to have more than one fee ticket for the same data service. So we can have that whole patient date of services on one encounter to be able to append modifiers and send out the full claim. So for us, it's really been a much more automated process and making sure that we don't miss any charges.
And Katina, I think it was, sort of brilliant on your part. You guys knew you needed to identify those opportunities for lost revenue. And I was your implementation rep, and you stuck with it about discussing that need and communicating with that till we created this approach. And it's not the idea of trying to create edits to capture lost revenue. That's not unique. People have drug codes and no admin codes, or injection codes and no drug codes, or a diagnosis that would always have a particular test. And so people do those things in edits. But I think what was novel on your side was to say, can we do this appointment type, and I think you're setting an example for others to question and to dream up ideas outside the box, to engage with White Plume, to pursue those solutions. And we appreciate you being that kind of partner. When we talk about CIS's workflow, I'll mention to everybody else, they don't just do the novel appointment type charge import. They also do part of their charge entry in their custom EHR tool. So they collect their office visits and EKGs in their EHR, and they integrate that with their Accela capture charges and these DFT orders with the appointment type. So we really merge all that stuff together for them in an interoperability model that serves them well. Or I'm speaking for you, Katina. I hope you would say we serve you well in that.
Absolutely. What I most appreciate is the flexibility and the creativity that we all come together to try to resolve an issue. Again, for us to move from paper to an electronic charge capture system was monumental.
And you have a demanding staff that want creative and automated solutions, and they're willing to articulate those needs and power through them with us collaboratively in order to get them. And we also didn't mention you guys use Accela Mobile for your hospital charges. So you're really a robust user of lots of features at White Plume, and we thank you for being a partner like that. Shelley, are you getting a question? And so guys on the phone, if you have questions or clarifications, Shelley is monitoring the question panel.
Right, and one of the things too, it might help you, and I was remiss in doing this a little bit earlier, but the people in this room and people on the call that are supporting you from White Plume, we mentioned Stuart Wiggins, of course, from the implementation staff. We have Allison Singer, who many of you have worked with Allison. She's super from helping the customers really understand their workflow and developing the forms and the capture items with respect to that, and building in some front-end logic with that as well. She's participating. Carol Johnson is here, our Vice President of Client Services. I believe Carol actually did the install, the original install for one of our panelists in 2000. And she hasn't changed a bit, I'll tell you that. Carla Granger is here as well. Carla has worked with you. I think Katina would testify that she really, really knows her part of the world. She knows it well. And she handles a lot of the tough rock, what I call the big rock issues when it comes to development and interfaces and APIs and the like. And she's on this call. Catherine Baer is on this call, another talented CAE, and I mentioned Shelley Wiggins as well. So Sally Miller is also participating. Sally is one of the CAEs. And just so you'll know, the CAE's role here, if you haven't heard this, is we're the ones that do your primary advocate in we're the ones that want to hear, we got your back, okay? So that's the people in this room.
All right, so do we want to move now to our next panelist? That would be Kathy Dorvey with Capital Care, who's going to talk about edit maximization and her use of Accela Smart Validation Rule Engine. So Kathy, are you there?
I am. Welcome, everybody. Katina, that was great. I actually learned a few things myself today, so I'm already excited and wheels are starting to move. I have worked with White Plume since about 2000, and we have, as you said, that interim effect. We have grown, and when we need something, we move forward, and that works with all of our edits also. When we're creating our edits and so forth, you know, we start off in 2000 with our basic edits, and we listen to what our staff was having to stop at, and then we start to think about how can we make it a little easier for our staff, and then, you know, how to create and grow and make the rule expression be just a little bit more robust. But always thinking back, as you know, it's a new day, and every payer changes, different things happen throughout the year. So we really try to take our edits and listen to our staff, not only our charge entry staff, but our billing staff also, to be able to create the most up-to-date rule definitions that we possibly can. We have, I think, over 2,000 edits in our system that we have in place. We have multi-specialties, and one of our greatest challenges that we've had is with, you know, one of our payers, and we do a lot of preventive exams, and as you can see on the screen here, this is an example of one of our rule definitions that we have in play that I'm still testing it a little bit. So in my brief description of it, I always write test to begin with, and then I make notes in the expression as I'm moving along. But building the edits, I try to think about the who, what, why, where, when, and how we can master creating these. Think about what the payer wants, how the payer would like us to have the claim be processed and so forth. They have certain regulations that they want, as well as following all of CCI and, you know, all the different edits that we have in play. So we go ahead and we look at the procedures, and in this particular case, if you go to the next screen, when I first started with the preventive diagnosis, it has to be primary on all the charge lines. It was for a specific payer. That payer wanted to see the supporting diagnosis following the preventive exam. Otherwise, we're talking about, you've got a patient may end up being responsible for a copay that they wouldn't generally be responsible for. We have an in-house physician office lab, so they could get an additional copay. So, you know, we didn't want to upset the apple cart with our patients getting bills when they really shouldn't have been receiving bills. So we've taken that, and when I first started out, I looked at, all right, anytime we use disease, you know, or a preventive diagnosis, we want to have that in the primary slot. So I created an edit to say, you know, is it primary? Yep, that was really good. But then we have to think, well, for Medicare, we don't want to have that. So we have to start thinking about, all right, now we need to define the rule just a little bit more, adding more definition into our rule by adding insurance. When we do all of that, if you go to the next screen, you'll see that we get all of the rule definitions down on the bottom. We might get multiple rules that will fire based off of that. So one of the
Kathy,
things that,
Hey, Kathy, can I point out to people who are watching the slides with you?
sure.
Kathy, I mean, so number one, you're hearing her say that it's an evolutionary process, that over the years, the rules become more robust and more granular, more specific as they identify the needs. So that's ideal. That's not a one and done. Those rules grow as they identify more sophisticated scenarios. So they do that. I love how her expanded text, she uses rules there to say, now this replaces that other rule that you are used to looking for. Or this is the rule that I created this time. Some people use that custom field in the bottom right when you build an edit, but she's got it built right here in the expanded text so that her experienced users know more about what to do and why they're doing it. So I thought that was kind of a cool way to use that. Not everybody does that, Kathy. So sorry to interrupt your flow, but I didn't want that to pass people by.
No problem. I actually use that also if there's a particular policy, a Medicare policy or a different policy for an insurance that is specific to that rule. That gives me a quick go back, oh, I need to go look at policy number AB, you know, or whatever the rule, or whatever the policy is that the rule was created from. So in case that there was an update to that rule, I can again go back and take a look at that. So.
And Kathy, did you, so you guys didn't start 17 years ago with AccelaCapture and AccelaPass. Did the need to move things to primary, did that kind of come along with AccelaPass because the charge capture you had made it harder for them to rank and link and sort those diagnoses, or was that inherent back in the scanning days or in the initial AccelaCapture days? In
the scanning days, we really only had so many diagnosis
choices, yeah.
Choices. And so, yeah, on the charge passing now, they can give us up to 12 diagnoses per encounter. And if, you know, and in times, you know, they've exceeded that 12, so we actually have rules to say, all right, if you've given me 13, I need to take a look at this type thing. But it's allowed us to expand and use up to 12 diagnoses. But again, with that, you get multiple edits. The examples that I'm giving are basically on preventive, but if you've got a Medicare who has a preventive exam, they may have seriously up to those 12 diagnoses. And we want to make sure that we're, you know, capturing the most up-to-date information and passing the correct information through. So it allows us to be able to then check back with the providers if necessary, if we see any questions in regards to any diagnosis listed and so forth.
Right.
For preventive. It allows us to use the most up-to-date screening diagnosis codes versus, you know, just a specific diagnosis based off of the procedure codes. So we get a lot of flexibility in regards to when we're creating edits. You know, if we're using I'm going to call out Medicare, you know, if we're using a G code for their screening, we want to make sure that we're using the appropriate screening codes. So if we get say a PSA that has a screening diagnosis code, I can build an edit to say, did we really want to do a PSA, or was this a screening? And we can then bring it back to the providers and so forth.
Well, and talking about PSA makes me remember, you guys are really robust users of every attribute that you can build a rule on, as I remember, that you build rules based on age, whether they're age appropriate, whether they're gender appropriate. You look at units, referring doctors, and like you said, you've got those specific things where if a particular code needs to be different for a carrier, you've got that down to say, yes, they chose this standard code, but the particular carrier needs a customized code for billing. So I know you do that.
Absolutely.
One thing on that, go ahead.
We can definitely build it even by location. We have multi-specialties, you know, so some of our specialty sites don't even do any labs. So we don't want items firing for those particular locations that aren't necessary. So it's really, definitely getting into age, provider, aux providers, duplication. If we have a in-house lab, it drops the charges to the encounter based off of an order, but whoever is reviewing may not have seen that order and added the test again, where we can capture that duplication. So we do have quite a robust file of edits in place.
And I noticed a feature you used on the screen before where she was building the rule, Kenny, if you go back. You had mentioned you benefited from a site visit where you had a White Plume employee come and just kind of question and brainstorm with you, and just together you focused on how the programs and products could be maximized. And so you added an attribute to some of your custom edits. Would you speak to that? The procedure is okay. Remember you told me about that yesterday?
Yes, absolutely. Again, with the preventive exams, we have a large amount of them, so that we will have a large amount of edits. So to clean up the edit process for my staff, if as they're going through and they've made sure that the diagnosis is primary and then the supporting diagnosis is secondary, they've already cleaned up the edit, they can add a procedure code OK to the encounter that does not pass through into our APM system, but it will allow the edit to then no longer fire. So it's kind of resolving I've already checked this particular edit, and we can move forward.
So at revalidation, it doesn't appear, so it cleans up your second and third pass.
That is correct. So it's similar to how Katina works with her office visits. The OK works for our edits in this particular instance. So,
so it exists there long enough to manipulate edits based on, but the attribute we assign to it keeps it from passing to your practice management system.
Absolutely. Absolutely.
Another point I remember you making with us, I think, in our conversation yesterday, in those 2,000 edits, you have got some high volume edits that hit a lot, but they may not have a great big dollar impact. But then sometimes you might have more robust or difficult or high dollar edits that don't happen very often, but they're important when they do. And so, I think that was one point we wanted to make to everybody on the call, is that there might be some things that require more scrutiny and more nuance, but spending that extra time on those edits, even if they don't show up very often, and even though they're a lot of work to build, they can have a high dollar impact. So I just remember you saying how much you invest in all attributes of your rules.
Yes, I do. I really try to take and think about how it affects, where it affects, who it affects, and like you said, it may be a small portion, but it is high volume, and we don't want to be losing that revenue by not capturing that information. So.
And hi, this is Debbie. We have being multi-specialty, but mostly primary care, every little widget counts. So, it's not just those, as you said, those high dollar ticket items. It's every little flu shot counts. You paid for the vaccine, you need to make sure it can get out the door and that you can get paid for it. And we have, we've more than doubled our size in the last, as far as providers and sites in the last 18 years, but we have not had to increase our staff, which I think is a test for charge entry, which is a testament to White Plume, AccelaSmart, the rules, and how well Kathy manages this product with her staff. It is amazing how many encounters we can process on any given day and still have a 99.8 or 9% clean claim pass rate every single day.
That is awesome. Thanks for that testimony. And Kenny did some numbers talking about the volume, right, Kenny?
And several of you may have missed this early comment, but we were running some numbers based on Capital Care's history, and they kind of work over there. They've done over the last 17 years, they have processed over 7.4 million encounters through our product suite. And you think about that just firing with the standard rules, but when you add 2,000 edits above that, the kudos that are deserving for you guys are just everywhere. They're everywhere.
Kathy's talked about the growth that they've had there, and it has been phenomenal. The number of doctors that they grew, and then also, Kathy, I think you started like as an infant, but didn't you tell me you've been there 32 years?
I have been with the providers for 32 years, yes. Yes.
And you've used White Plume for over half that of your career for 17 years. So that's pretty amazing to us, because we all still think we're young, and we think White Plume has just been around a couple of years. When we think that we have impacted your practice for over half of that period, it's remarkable, and we're happy to have been your partner during that. So.
I was actually in middle school when I did that.
I remember. Yes, Carol.
We have more than half of our staff actually that have been with us through that whole 17 years. We have about 22 billing people in the department from all aspects of billing, not just charge entry. But about half of them have actually stayed with us for that entire 17 years, which is, to me, amazing, particularly in this day and age. It's great. So,
that's awesome.
You know, one of the main things to take away is any edit that you create, you know, you can always take a look at it again and see if you can maximize it. You know, we recently changed our practice management system, and we've needed to add additional verbiage to some of our edits for secondary insurances. So those weren't firing. You know, we only want an edit to fire on our primary insurances. So we've been always evolving.
yes. Kathy rocked that, I have to say. She rocked it. We actually went, and then I'll be quiet, we went from a practice management system that we have been on since our inception in 1999, all the way through until May of this year. We finally changed practice management systems. And I have to say that the lowest that our clean claim rate got, even on the initial days after that, was like 98.9 or 99% clean. That was the lowest, and that only existed for a week or so. We did not lose $1 in revenue. We had about a 5-day delay, that's it. We didn't borrow from the bank. We didn't do anything. We didn't miss a beat. Revenue pretty well stayed the way that it needed to, even though we changed systems on both sides. So it was pretty amazing feat, and I couldn't be prouder of this team. They really rocked it.
That's really a testament to your team. We agree at the quality of staff that you have there. So thank you both for all those contributions.
Thank you.
Yeah, do we want to move to Connie? So we now have Connie Dodson. She is with Shannon Clinic in San Angelo. She's going to talk about interoperability and integration. And, you know, Debbie and Kathy just talked about this year, they've changed practice management systems. Connie's right up in the middle of that and is engaged in that process. Matthew wants to kind of talk about how we got there. Connie, can he do that first, leading up into your conversation?
Sure, that'd be fine.
Okay.
Yeah, let me give you just a little bit of background information, because Shannon Clinic went through a large change this year, just like Capital Care did. So let me give you the before picture. What Shannon Clinic was doing, they used AccelaCapture for the majority of their office charges. That's the electronic superbill to capture all of the data prior to sending that to AccelaSmart. They also had lab charges coming in through a separate interface. That's something that many of our clients do, but certainly not all. So that may be new for some of you, kind of the thought of charges can come in from a lab system or a radiology system. If you need an external charge feed and you want that to go through AccelaSmart, that's something that Shannon Clinic did a great job of before they sent all of their charges to Vision. Yeah, that was the practice management system that they were using to receive all of the charge data. They had used Vision for a long, long time since they had started using with AccelaSmart. And so that was what their workflow looked like. And what they were changing to was a new system, both on the clinical and financial side, for their inpatient and ambulatory practices. They were moving to Epic. And, you know, Epic has an integrated clinical financial record. And so when Connie and her team started talking about AccelaSmart and what does that look like in an Epic environment, they were trying to do some education for their team that was working on the Epic project. And so when they first started talking to Epic, they said, well, we have an editor. We have a way to do code scrubbing within our system. And the tricky part about that is when you say we have editing or we have code scrubbing, that can mean lots of different things to lots of different people. And it was not out of a position, you know, Epic was not trying to be difficult about this, but they really didn't know what Connie and her team did in AccelaSmart. So they had to have a conversation. They had to educate Epic a little bit to explain what they were doing currently with AccelaSmart before the charges got to Vision. And as they started to do that, it became clear that there was a need for AccelaSmart in addition to what Epic could provide, but there was a problem. Epic was very concerned about maintaining what they called the integrity of the charge record. They wanted to make sure that they didn't want to insert AccelaSmart in the middle. Now, that could sound like a deal killer to most people, but you don't know Connie. So she was able to very clearly explain to them what it was that she needed, and then we were able to work collaboratively together on a solution. So let me, hopefully, Connie, I've teed that up well for you. Do you want to explain just a little bit about what you had to educate Epic on and why that was so important to your team?
Sure. And thank you, Matthew, for leading me into this. I too have been with Shannon a long time. I tell everybody I started at the age of 10. I really didn't, but I've been here 32 years. We also too were a paper engine, and as ICD-9 developed into ICD-10, and White Plume joining our group and us joining White Plume's group, we realized how much, you know, that extra piece added to our success for getting our claims out the door clean. As I started with, and this conversion with Epic is my fourth also here, and it will be my last. I don't plan to do another one, but it was totally different. Our conversions in the past, myself and a lot of the business managers and scheduling managers and reception managers have all been part of the build team. So we were in there making the decisions, and we were in there seeing how the build was being done, and understood that better to make sure our workflows were going to work. Epic has a different approach, good, bad, or otherwise. It's just a different approach, and we're converting from a system we've been on for 15 years. So you know, it's a whole different ballgame for us. So we have a whole EMR team, an Epic analyst team that has been brought in to do our build, and it's very segregated. And we are a large group. We're about 280 providers, and we also have hospital-based providers. We do anesthesia billing, hospitalists, radiologists, things like that. So when they started the build, I was included on some things, but not as many of the things that I would have liked to have been included on. So as we started, I kept asking for, I want to see this. I want to see how this works. I want to see from the time the patient enters the door, they're checked in, the nurse, they're triaged, all that stuff through the time the doctor does his stuff and drops the charges. Well, I was told, well, we really don't do things like that. And I said, but you don't understand. I have to see how this all works so I know what to expect for my staff. And like Matthew said, we were told they had this scrubbing engine. And as we got into it, we could see our custom edits. We have well over 1,000 custom edits in White Plume now, and they were able to mimic that. One of the analysts that was on the PV team was able to copy a lot of our custom edits into Epic. So as we started going through some of these scenarios, I kept seeing our custom edits and I didn't see anything else. And I kept asking, I'm like, where are our CCIs and where are the MUEs? And my coding staff, I have some coders with me that have been well over 10 years here at Shannon. They knew what to expect. They knew what they should be seeing, and we weren't seeing that. And I just couldn't get a straight answer as to what. Well, it comes to find out, it is there if you build it all out the way you want it. And most of you guys know with ICD-10, that's just next to impossible. So that's when we pushed. I went to my director and I said, we've got a problem. I've got to have a scrubbing engine that we can rely on to get our claims out the door. And as we pushed and pushed and pushed, there were some clients that used some other engines, but it's really a different approach than White Plume. We are looking for just that scrubbing engine that we can use in our back-end coding and get our claims out the door. So it took some fight, and it took a little bit of time to get Epic to come around. Like Matthew said, their whole concern was that charge leaving their software coming back into their software. And we have some testing, I hope, going on this week. We were shooting for our go live, which was October the 7th. I think White Plume was ready, and Epic, they weren't quite there to send some stuff over. As most of you know, as you've gone through conversions up to go live, it gets pretty crazy. We're at the bottom of our 3rd week, and it's tremendously crazy right now. So we're waiting to do some testing with that. I feel like the transition is going to be very minimal for us because we're so used to what we expect to see in White Plume. Yeah, I fought really hard to keep my connection with White Plume and to incorporate that in our Epic transition. They do provide a strong, there's a place to build all sorts of custom edits like we did in White Plume, and we will do that. But they just didn't provide what we needed for, the LCDs, the CCIs, all the ICD-10 changes and what's required to get those diagnoses right and get your preliminary diagnosis, and you can't, these two diagnoses can't go together, and all of those things they didn't have. So myself, along with my director, but we worked and worked and worked, and they came around, and as visiting with them, I understood they were really clueless to what I was expecting to see. So we fought hard.
And you came up, and you came up with a non-traditional solution, right? I mean, so traditionally, as Matthew was saying, White Plume would be in between the EHR charge collection, then you would edit, and then it would land in the PM system in the in the financial world. And because of the architecture or the construction of Epic, that's just not the way they work. But you were tenacious, and we did come up with a solution. Matthew, do you want to speak to it or try to summarize that? Or?
Sure. So the way that it works is there's a work queue within the Epic Resolute system, which is what they call their PM financial side of the application. And so we are using those AccelaSmart rules to help populate their work queue within Resolute. So that way, Connie and her team don't lose the functionality that they are used to, making sure they get all the ICD-10 edits correct with all their LCDs and their NCDs and CCIs and medical and likely edits, that those are all firing right there when they need it, so that their coders can see all of that in the same place. So they're not toggling back and forth between multiple applications. And we think that's a really collaborative effort on the part of what Epic did and what White Plume had to do, but that would have been impossible without Connie and her team really advocating for that and making sure that they got all the people in the right room together to get that solution in place. And so so we're grateful, Connie, for the ability to continue to work with you guys and the ability to work with Epic in this. And like Connie said, this has been a brand new, something that we've been working on pretty hard for the last 60 days to get that ready in time for their go live that was at the beginning of this month. There's still some kinks that are being worked out, but we think we've got the right people on it, right, Connie?
Yes, and I know we already are seeing some of the effects of not having that in place. Not White Plume's fault by no means, but not having that in place because we already have some claims stopping, and it's some coding things that we wouldn't have missed if we would have, once we get this in place, I know, we'll be back on track. But like I said, anything with the go live, nothing always goes according to plan, and our target was to make it happen by our go live, but it didn't happen. So again, not on White Plume's part, I think Epic. This build has been huge for us. We are truly an integrated system with our hospital now. It's one medical record shared across the clinic and hospital. So every conversion in the past has just been on the clinic side, and the hospitals always had their own EMR. They've also always had their own PM system, as the clinic has. And so this conversion has been huge. It's a totally integrated system, one medical record across both entities, and so there was a lot of build, a lot of new things that we haven't faced in the past. What we will be doing is also our hospital charges that our providers generate will also be going through the Epic interface, and we'll be able to utilize the White Plume product. They were all manual prior to Epic, so it's going to be like Christmas for them because they haven't had the advantage like we've had.
Right.
They've been totally manual up until Epic, so they're looking forward to seeing these fire for them for the services our providers do in the hospital, and be able to start building some of their own custom edits that are unique for them for the inpatient and outpatient billing. So
thank you for that, Connie. And some people on the phone might be saying, well, that's a great story and good for her, but I don't have Epic. But the takeaway from that is that's not been unique to Shannon. We've got clients who have spoken up for their needs and engaged White Plume and their PM vendor, whether it was their established PM vendor and they have said, we need more features. We need you to pass this item. We need to include this element. And we were able to co-develop with them and have new features that were available for all clients. And then sometimes some of you have said, I need this, and it's out of the box, and they have worked with us, a vendor or a VAR, a reseller or a contract resource, to say, I need you to do something special just for me. And White Plume has worked up. Cardiovascular Institute is one of those. They've done special stuff. Our outbound interface to their vendor is unique to them to accommodate what they need. And Orthopedic Institute is on the call, not as a presenter, but they're one of our newer clients. And again, said, we need these things. We need to engage, and got the resources together so that their vendor is receiving data in a way that has been non-traditional, but they were tenacious, and we worked with them, and they worked with their vendor, and moved the ball forward to accomplish what they need. So I think that's sort of the theme of today is there a germ of an idea in what somebody else has done that I can take away, and a seed that I can plant and grow. And because Connie's theme was interoperability, I do want to mention two elements, and it was on the screen that you were just on, Kenny. So APIs, and that's an application programming interface. It's just think about on your phone. You've got a phone, but you can plug in apps. Well, in 2015, the rules for certified EHR technology, EHRs were required to make available APIs to other systems. And so some of you are integrating and having interoperability with your vendor for things like where your AccelaRATE diagnosis or your visit type can go back to the EHR so that that doesn't have to be entered twice. Some of you, the minute you were using AccelaCapture and an EHR side by side, were lobbying right away and said, we're doing this twice, how can we do this once? And it took the vendors working together to accomplish that. We've got on the bubbles coming soon, order entry via AccelaCapture, so that's coming around. We've got vendors that allow us to archive. Now, we've had archiving where we can, you don't have paper boxes and banker boxes to store offsite anymore, but people were worried about keeping copies of their tickets for research. We've been able to put those onto the network in a PDF file, but some of your vendors will allow us to send that in, and it's integrated into your clinical record. And then there are plugins where you could be in your EHR, that's your home base. Your doctor doesn't want to have two applications and toggle between, and there's so many keystrokes and so many applications and all their demand. And so we've got some vendors that offer that. So you're in the EHR and you just push a button and boom, there's your ticket. And you save the AccelaCapture ticket and they're back in the chart without having to look for the appointment or sort for that. And then some of you have worked to create that, not necessarily, Carla, am I saying this right? Not necessarily with the vendor, but they've still launched that from within their EHR using tools that we've given them. So when you think about what's going to make our practices process better, we just, I think, are saying here, and we're encouraging you to engage us in the dialogue. Your CAEs are asking those questions, trying to mine those ideas to see where we can deliver and accomplish better things for you. So I think those were the big points we wanted to make. Or is this where we wanted to see if, Shelley, have you been accumulating any questions? So we have a bunch of quiet listeners.
We do have a bunch of quiet listeners.
When I look at our attendees, I am just surprised that we have quiet listeners because we have a bunch of smart, inquisitive people. But
yeah, and I want to just say thank you, everybody, for your time today. This is an initial effort on our part and something that we hope to continue going forward. But as Kenny was saying in the beginning, we want this to be your agenda, not ours. We want to hear from you and get your feedback. Was this helpful? Were you able to learn something today? Is there something that you're able to take away and implement in your practice? Maybe you heard an idea that is not 100% transferable to your organization, but makes you think of something else that you need to be doing. We want to start having more of those conversations with you. So if there's something that sparks an idea, talk with your CAE about it. Maybe there's something that we have done at another client that we can leverage in your practice. But all of that starts with the discussion, right? We need to hear that from you. That's where our best ideas come from. So I just want to thank Kenny and Shelley and Stuart for all of their work on the front end. I want to be able to thank Katina and Kathy and Connie for their preparation and their willingness to share their stories with all of us this morning. I hope that that's been helpful for you. We will have a short survey at the end when you sign off of the webinar today. So if you don't mind spending 45 seconds, a minute to answer those few survey questions, that would be super helpful for us, making sure that we make this better next time. Because there will be a next time. We will be asking some of you to help participate and help deliver some content that's helpful for other clients. So I appreciate that in advance. So with that being said, did I miss anything else? Shelley's telling me I missed one thing. There is one final poll question. So the question is, based off some of the things that you may have learned today, how do you feel? Is this something that you're going to kind of take up in the next 6 months and try to make some changes to improve your use of AccelaSmart? If you need help from White Plume, we are here ready to help you guys. If you need some help with ideas, we're happy with that. If you think that you are doing a great job, nothing to improve, that's okay too. We're very proud of the hard work you've already done. But just let us know. We'll share some of those survey results. Shelley, what are we seeing so far? Where are the answers falling? All across the board?
We are half and half on 1 and 2.
Okay.
Okay.
All right, great. Well, glad.
And this question is not the same as the survey they'll get when they.
That's correct. This is different than the survey. These are poll questions. So we have Shelley saying we're right neck and neck on those first two. Yes, definitely, I'm going to be making those changes on my own, or yes, I need some help. So we are happy to help those of you who need help. Thank you again for your time today. I hope you have a great weekend, and thank you guys for being wonderful White Plume clients. We are grateful for you. Bye-bye.
Thanks, everyone.
Bye-bye.